So I'm a child and adolescent psychiatrist, and I've spent 20 years working in clinical medicine, and I am most disillusioned with the picture that we have. My patients are being failed. The treatments we have they lack efficacy and they're not safe, and our patients are demanding more. And particularly, what we need to do to embrace these psychedelics and their role in clinical medicine is understand this developmental trajectory. That this is a small, bruised, humiliated 10-year-old girl. And the inevitable trajectory that goes from child maltreatment and abuse into adult mental disorder and particularly addictions. And we forget that, because what we're actually looking at here is a 40-year-old. She's sitting by the bus stop and she's begging for some money. Don't give her any money. It's her fault. She'll only spend it on booze or drugs. She could stop if she wanted to. She's HIV positive now, she's hepatitis C positive now, she's alcoholic, she's an intravenous heroin user. But it's a lifestyle choice. Now that's outrageous, isn't it? But that's what we do, and this is the real problem. It's the lack of compassion, but also the lack of the scientific knowledge about this developmental trajectory. If we're going to win this war on mental illness, we need to understand that. So I'm going to talk a little bit about child abuse and maltreatment. I'm going to talk about a very dangerous legal high, and then the work we're doing in Bristol with a groundbreaking world's first addiction study with MDMA. So we know all about different forms of child abuse, and the two biggies there, sexual abuse and physical abuse, they're the ones that sort of get the attention of social services. But don't take your eye off the ball with emotional abuse and neglect. I've worked with a great many young people and young adults and old adults who are severely mentally ill and with personality disorders and addictions and PTSD, and it's without the biggies, sexual and physical abuse. This drip, drip, drip emotional abuse. I don't love you. Your dad doesn't love you either. We didn't want a boy, we wanted a girl. You're loveless. You're worthless. You're a slut. You deserve to be hurt. You deserve to be exploited. There's no physical abuse going on here, but that kind of emotional abuse is extremely damaging. And then people with end-stage mental health problems, including addictions, often have these multiple psychosocial factors as well. And so those of you working in mental health would know that you work with the people on the bottom rung of the ladder. These are not only the people with the poor parenting and the attachment disorders, they also have the parental criminality, high levels of drug misuse within the family, transgenerational unemployment, poor housing, poverty, racism, exclusion. We work with multiple risk factors in mental health. And that can make it a very depressing place to work at times. But another way of looking at it is look at all the therapeutic opportunities to intervene here. And as psychiatrists, we might do a better job if we just all became social workers. And a good psychiatrist is a holistic doctor that does care about not just the medicines or the psychotherapies, but where your patient lives, what they eat, how their children are, how their family is. Excuse me. So we have to be holistic to tackle this. It was a good night last night. So a little bit of a brain physiology refresher here. The red area there is the amygdala. All mammals have the amygdala. It's part of the brain that fires in response to fear and stress. And it's a bottom-up, knee-jerk reaction. No higher thought is required. You feel the threat, your amygdala fires, it then triggers a hormonal reaction called fight, flight, freeze, and it says, get out, you're in danger. Now, the green area is the prefrontal cortex, a much more sophisticated part of the brain. Only humans have this. This is where we use judgment and reasoning and rationality, and we can overcome this instinctive amygdala response with this rational, well, I don't think I am in that much danger. I reckon I can figure this situation out. Now, if you grow up in an environment where you are kicked and punched and raped and burned with cigarettes, you develop physical brain changes. Your brain physically develops with an exaggerated amygdala response and a shrunken prefrontal response. And the result of this is that you build up these very rigid narratives about yourself. This becomes a neuroadaptive response. In order to protect yourself from this noxious environment, you build up these narratives about the self. I am bad. It's my fault. I deserve this. And narratives about the world as well. The world is dangerous. Trust no one. I get patients to look out of the window in the clinic where I work in Weston and look at the people walking down the street, and I say, you know, what do you see there? What do you look at the people in the street? And they say, he looks dodgy, she looks dodgy, I wouldn't trust him, she'd screw me over. And I say, it's weird, because I look out the window and I say, he looks really nice, I bet she'd be my friend, I bet he'd help me out if I needed some support. So we're seeing the same people, so there is no objective reality. Our reality is very much governed by our early attachment experiences and the extent to which these very core features, what is love, what is trust, what is friendship, is it okay to drop litter, is it okay to hit people, is it okay to lie and cheat and steal? And you develop these narratives to survive. So the patient who later in life presents with adult mental health problems, who is stigmatized and labeled as a liar and a cheat and manipulative, when I see these patients, I say, good for you for lying and cheating and manipulating. Because nobody was looking after you as an infant, and if you hadn't become this hard-shelled person, you'd be dead by now. So it's a neuroadaptive approach that protects the patient. But it's so difficult to hold these narratives that the most attractive prospect for a person who's had these experiences simply to blunt the edges. And this is why we see such high levels of substance misuse within this traumatized population. Now, it's very hard to treat childhood trauma or the adult manifestations, and there's no single drug or single psychotherapy to treat PTSD. We have a whole host of stuff, what we call polypharmacy. If the patient's depressed, put them on an antidepressant. If they can't sleep, put them on a hypnotic. If their mood goes up and down, put them on a mood stabilizer. If they're hypervigilance, one of the core features of PTSD, if that spills over into paranoia, put them on an antipsychotic. So they're on so many drugs, none of which actually attack the root cause, the trauma. They just paper over the gaps. And I think of this as a good analogy would be having an infection. Now, if you have an infection due to a bug, a microorganism, one of the symptoms is a high fever, a temperature. And you can take a drug like paracetamol or ibuprofen, brings down your temperature a little bit, it makes you feel a bit better. Sure, why not? Good thing to do. But ibuprofen and paracetamol are not antibiotics. They're not going to kill the cause, the bug. They just treat the overlying symptoms. And that's what we do in our treatment of PTSD and most adult mental disorders. We treat the overlying symptom by papering over the cracks. It's not good enough, it doesn't work, and the patients don't get better. This is why we have a 50% treatment resistance. The other reason that these disorders become chronic unnecessarily is that the psychotherapies are also ineffective in 50% of cases. Because by the time the patient's in their 20s, 30s, 40s, 50s and they're alcoholic, they have become an expert at papering over the cracks. They've become an expert at avoiding that question, tell me about your rape. Everything they've done in their life, their heroin, their alcohol, their self-harm, their admissions into hospital, it's all in order to not think about that night when they were 8 years old and that thing happened to them. So they sit down with a therapist and the therapist says, let's talk about your rape, and they're out the door and they're back to the bottle of vodka. So very hard to treat this group of people. Now, we have a serious problem with alcohol in the UK. I think a lot of people around the world don't recognise this as much as, or rather we don't recognise it here, just how bad it is in this country. It's a massive epidemic. It's so cheap, it's so available. A bottle of, a can of lager in Tesco's is 49p. The equivalent bottle of water is 89p. We have an absolute epidemic. Every single shop, newsagents, petrol station sells cheap alcohol, and we're walking into an epidemic here. And how well are we doing to manage alcohol use disorder? Well, there was a good slide actually from Emily in my symposium on Friday. And this is with the very best that alcohol, that the medical profession can throw at you. So AA, MAPS groups, one-to-one psychotherapy, group psychotherapy, rehab, detox drugs, anti-craving drugs, the very best thing we can throw at you. What have we got? We got 90% of people drinking again within 4 years. Now that is not good enough, okay? We've had 100 years of modern psychiatry, and that is a very, very poor outcome. And I can't think of any other parts of medicine that would tolerate such bad outcomes, but we seem to be sleepwalking into this. So we did a little survey in Bristol. We screened people before they had a detox, then they had their detox, Then we didn't do any treatment. We just followed them up at 3, 6, and 9 months with whatever treatment they were undergoing. And at 9 months, we've got the outcomes there. Out of these 11 people, 3 of them are dry, and the other 8 are still have returned to their levels of drinking before they came in. So pretty typical picture there of relapse after detox. So that was what we would call our sort of treatment as usual control group. This isn't good enough. We were doing better at treating alcoholism in the Victorian times than we are today. We need to do better than this. So, if only there was a drug that could assist us in our treatment of trauma. Now, 3,4-methylenedioxymethamphetamine is quite a remarkable compound. It's a very varied compound. It's not just a simple one-off mechanism of action. It works in many ways to tackle this problem. And if you were going to design a drug to assist trauma-focused psychotherapy, you would design MDMA. And now, would it work to treat alcoholism, though? And this is one of the questions we asked ourselves when we set up the study. We know that the classic psychedelics have a very rich history in the treatment of addictions. In fact, most of the work in the late 50s and early 60s with LSD was actually for alcohol use disorder. It's very well established, and we've got contemporary work with psilocybin on a range of different addictions, including alcohol and opiates and cocaine and nicotine. So the classic psychedelics have a good history. And all of these classic psychedelics, let's throw ketamine in there as well, Krupitsky's work, all of these treatments for addictions with classic psychedelics, one thing they have in common is it's the depth of the peak experience, the mystical, mind-blowing, meeting God experience that seems to be the factor that brings sobriety. Whatever the substance you're treating or whatever the classic psychedelic drug you use. Now, MDMA typically does not produce a mystical experience, at least not very often. About 10% of first-time threshold dose MDMA users will report communing with God in a spiritual way. Nothing like the 80 to 90% that you get with LSD and psilocybin. So maybe it wouldn't work, and this is one of the questions we asked ourselves. But what we do know from the work with PTSD is that MDMA has this very specific and excellent response at treating trauma and empathy. So we put 2 and 2 together and figured, let's be the world's first team to use MDMA to treat an addiction and see what we get. The perfect tool for trauma psychotherapy. It's short-acting, 2 to 5 hours, mildly perceptually disturbing, enough to make you sort of think outside the box and think creatively, but we're not talking dripping walls and melting faces, but enough to be thinking, can I see this in another way? Almost always pleasurable, very important aspect of this. There are a few drugs in psychopharmacology that are so predictably tolerable and pleasant to take, the opiates being another group. I often say to my medical students when I'm teaching them, if you don't like heroin, you haven't got a brain. If you find you don't like heroin, you seriously need to get down and see your neurologist pretty quickly because there's some wiring gone wrong. So there are a few drugs that are hardwired to be pleasurable, and MDMA is pleasurable. Now, I'm not for a minute there saying there are no problems with heroin use. That's a pharmacological statement. Very safe. Now, when I started talking about MDMA 15 years ago, I used to put up reams and reams of data about safety and hyponatremia and hypothermia and trying to justify it to myself and the world. I don't bother. I just give you that one sentence. It is a staggeringly safe drug. It's not 100% safe, nothing is, but staggeringly safe. We're looking at 750,000 doses of MDMA being taken in the UK every weekend. 750,000 doses every weekend for the last quarter of a century. Yet the rates of morbidity and mortality are staggeringly low. Maybe 5 deaths a year once you take into account other factors, all of which could be avoided. But what you can definitely bet is all 5 of those deaths get on the front page of the Sun, leaving this perception that it's a dangerous drug. If it was a dangerous drug, we'd know about it by now. So it's not 100% safe, but it has a very good safety profile. It's a phenethylamine. You know, there's many ways of classifying the psychedelics, and there it is as a phenethylamine. It's an entactogen with a whole load of other drugs in that series. Now, how does it work? Well, so it's got an effect on the 5-HT1A and 1B receptors. This is the sort of positive felt mood, the euphoria, the sort of ecstasy aspect of it, which is very important and to provide that emotional state in psychotherapy. Has a slight mild effect on the 2A receptors where the classics work, but as I say, nothing like to the same extent as the classics. Then it has this interesting paradoxical effect. The amphetamine part of the molecule causes a stimulation through dopamine and noradrenaline. This increases arousal and allows you to engage in therapy. And paradoxically, at the same time, through the alpha-1 and 2, we've got a relaxation. So any of you who might have tried a substance, supposedly MDMA in the drug ecstasy, will be familiar with this strange sensation of being speeded up and slowed down at the same time. Makes it a very good tool for accessing psychotherapy. And then it has this hormonal effect with the release of oxytocin. And as we know, oxytocin is secreted from the brains of breastfeeding mothers, fosters a sense of bonding and attachment. And there's our traumatized brain, the physically changed, hardwired brain as a result of years of childhood trauma. What does MDMA do? Switches it round. A study done at Imperial in 2012, it boosts the prefrontal response. It makes you better at seeing the good in things and yourself and the world. And it shrinks the amygdala response, takes away that fear. So I love this phrase, it selectively inhibits the fear response whilst leaving the other faculties intact. That's really important. Many drugs inhibit fear response. Bag of heroin inhibits fear response. Bottle of vodka inhibits fear response, and that's why these are the drugs of choice for people with trauma. But they're messy drugs. They mess up everything. You can't think and reflect and remember and debate on those drugs. But MDMA does it so perfectly without messing up the others. And I'll share with you an anecdote. 1990, not yet gone to medical school, so I can say this. I was a DJ in the 90s, so this is how I came across a lot of ecstasy. And lying there after a rave, and we were all blissed out and lying there going, oh man, so beautiful. And then someone says, hey, let's think of the most awful thing in the world. And we went, imagine our mums dying. And we're lying there going, And then we're like, it's not that bad. Now, what's interesting about that, this is before I knew anything about MDMA psychotherapy, that's kind of what we do with MDMA psychotherapy. It allows you to go to that forbidden, painful, repressed, avoided part of yourself that normally you don't want to do. So combine that with psychotherapy and not just a bunch of stoners in their late teens, and you have a fantastic tool. So we put together this open label safety and tolerability study. An 8-week course, open label, so there's no control group, there's no placebo, and you may say, well, that's a not very good scientific methodology, but that's what you have to do when you do a first-time drug in a new condition. So it's the very first pilot study on this condition. The patients come in for a detox with chloride epoxide, then they have this 8-week course of psychotherapy, and then they have MDMA on 2 occasions. And typical to most psychedelic therapies, most of the sessions are non-drug. They're integration and preparation sessions and 2 sessions with the drug. And they take 125 milligrams, followed by 62.5 2 hours later. So 187.5 in each session, and they do 2 sessions. And then the follow-up at 3, 6, and 9 months. So I've mentioned this, the very good safety profile, and the important thing here is we cannot make inferences about clinical MDMA by what we see from ecstasy users, whatever they are. There are so many comorbid issues with ecstasy users, so many confounding factors. We have to concentrate on clinical MDMA and not look too much at the ecstasy using population. Because as we know, this is David's very famous Delphic analysis, and there's our psychedelics languishing down there. And here is the worst, most terrible piece of political folly of the last 50 years. If you learn nothing from this meeting, go to your MP and say, we need to radically overhaul the drugs policies because they are dangerous, they are unethical, they are unpoliceable, they are killing young people unnecessarily, they do not reduce the harms, they do not reduce the deaths, they do not reduce crime, they do not even, weirdly, reduce the usage of drugs. Why are they there? They desperately need to be overhauled. So just a few pictures of our service setting up. Michael Mithofer was due to be here today, but he's come and been part of that. MAPS have been very supportive. This is not a MAPS-sponsored study, it's independent, but MAPS have been there all the way with us. A few qualitative statements about how we're doing here, and really it's about the safety and tolerability aspects of this. Can we compare it with other treatments? And it's very well tolerated. So, and we had published last month the first study published around MDMA in addictions, and this is just on the first 4 patients, and we're going to be publishing the rest of the data later in the year. Now, physiologically, as I said, very safe, slight rise in temperature. We do the temperature every half hour and the blood pressure, but all within normal limits. This is good. People say, what about Black Tuesday, Blue Monday, Suicide Wednesday, or whatever people are calling it? We do not see this post-MDMA affect drop. We just don't see it. Every score below 0 is a positive mood. So we're not only not seeing this affect drop, we're seeing an afterglow effect. And this is because of the way people take it. It's very different from the way it's taken recreationally. So we're blowing open a lot of the myths here about ecstasy use when we look at pure clinical MDMA. We looked at a whole bunch of other measures like mental health and relationships and financial stability and quality of life and all the rest of those with massive improvements across the board. And this slide intentionally doesn't say much because basically all of that side shows that it's completely tolerated by people. We've got 12 people in the study at the moment. Everyone's pretty much found it fine. Now, at this stage, we've got almost the exact situation to the outcome study, the previous study. Most people are not drinking. This column here, there are a few people who've had a drink or two but have not relapsed to the full situation of going back to how they were, which is interesting because most addiction treatments aim at total abstinence. And if it's possible that MDMA psychotherapy for alcoholism allows you to return to moderate drinking, this would be a very, very interesting new development in treatment of addictions. I'm going to wrap it up to take a couple of questions. So most of the work with MDMA has been on PTSD. Most of the work with psilocybin has been around anxiety disorders, end-of-life stuff, addictions, and then we've got a whole load of other things. It's a great pleasure to be part of this wonderful community. Far too many middle-aged white men. We need to increase our diversity extremely quickly. It's a great pleasure to have been working on these over the last 10 years. I've variously been injected with intravenous LSD, DMT, ketamine, psilocybin, and I'm fine. And it's been a real pleasure dosing people and also receiving these medicines legally. So I can stand here as a doctor and say I've tried all of these things. I don't think there's any other doctors who's done all of them. MDMA, ketamine, LSD, DMT, and psilocybin legally. So it's a good position to be able to say that and talking to the press. Now, Michael Mithofer and I there in Cardiff, a lot of young people, I want to just finish by saying a lot of young people come up to me and they say, I'm really interested in this. You know, they're a nurse or a doctor or a student, a social worker, but my tutor has told me this is career suicide. And I was told that 15 years ago in Oxford. Why are you doing this? It's not career suicide. If you are interested in this subject and you want to pursue it and you are being put off by your tutors, you just have to tell them, open your journals, okay? Not a month goes by that psychedelic research is not being in the mainstream press, in the mainstream academic literature. These are not fringe organizations, you know, run by a bunch of weirdos in California. I mean, some of them are, but this is cutting-edge neuroscience. These are major neuroscientific institutions around the world and publications. This is not a fringe subject. This is the here and now of cutting-edge psychiatry. It's where the future lies. And whatever your discipline, whether you're a chemist or a botanist or a psychotherapist or a psychologist or a social worker or a physiotherapist or an artist or a lawyer or an architect or just a young person who's interested, there is a place for you in the world of psychedelic research. And we owe it to this population because we're failing them with current maintenance treatments. We need our antibiotic. We're not just symptomatic treatments because this little girl deserves our help. Thank you.